talking about the use of echocardiography in structural heart disease. Thanks for having me here. I have no disclosures. Given the importance of echocardiography in structural heart disease, I think there's clearly too much to cover comprehensively in just 60 minutes. So in today's session, I'll focus on the use of echocardiography after Tavor, the use of echo in evaluating patients for MitraClip, the post-MitraClip transthoracic evaluation, the use of transesophageal echocardiography in evaluating patients for the Watchman device. Then I'll end with the role of TEE in evaluating patients after Watchman's. Currently in the United States, the TVT database mandates reporting transthoracic echoes immediately after Tavor, 30 days after Tavor, and 1 year after Tavor. Included in that mandatory data are the aortic valve area or the effective orifice area, the peak velocity, the peak and mean gradients, the dimensionless index, and the degree of paravalvular leak. In order to report this data, it's key to understand the standards for Tavor measurements. In calculating the aortic valve area, or AVA, also called the effective orifice area, or EOA, there are standardized methods for measuring the LVOT. Measurements of the LVOT should be made from outer edge to outer edge, as identified by number 1 here. You want to make the measurements in mid-systole, and for the LVOT velocity assessment, the pulse Doppler sample should be placed right at the stent edge, and you would get a spectral Doppler tracing similar to this. This is the most common place for the sonographers to place the pulse Doppler sample. If for technical reasons, however, the outer edge of the stent isn't visible, you can still use the inner to inner measurement. However, it's important to remember that if you use the inner to inner measurement, you have to then place the pulse wave Doppler sample volume within the stent and not just at the stent edge. The lower spectral Doppler tracing here is an example for the same patient if you place the PW sample volume within the stent. What you can see is that the velocities are much higher if you place the PW in the stent rather than the stent edge. That will account for the lower diameter that you would measure with the inner to inner rather than the outer to outer. Inappropriate measurements of the LVOT post-Tavor are the most common source of inaccurate AVA measurements, where they'll use the inner to inner measurement instead of the outer to outer, and they'll pair that inner to inner with the LVOT pulse Dopplers placed at the stent edge rather than within the stent itself. If you use these inappropriately paired methods, this leads to an inappropriately small EOA. So it's really important, just as a general rule, I would recommend using outer to outer, and then you can use the standard pulse Doppler sample volume at the stent edge. For the SAPIEN valve, there are really 4 sizes. The valve is basically a cylinder, so the outer to outer dimension is usually within 2 millimeters of the size. In this case, this is a 26 millimeter S3 valve, which corresponds to an LVOT dimension of about 24 millimeters. If you're measuring the LVOT for an S3 valve, and you're getting a measurement that's more than 2 to 3 millimeters smaller than the size, you're probably measuring it wrong. So that's an important kind of check to keep in mind. The core valve, on the other hand, has a totally different shape. It's funnel-shaped, and the valve is actually supraannular and sits in this region. The size correlates with this diameter and not with the inner diameter. So the LVOT size is usually about 5 to 8 millimeters smaller than the actual size of the valve. Again, you still want to measure outer to outer. So remember, for the SAPIEN 3 valve, the LVOT should be within a few millimeters of the size, and for the core valve, it will often be much smaller than the actual size of the valve. Normal values have been published, and I'm showing this for reference only. I think the main thing to keep in mind is that for the SAPIEN 3 valve, the dimensionless index is relatively fixed for every size. So remembering a DMI of 0.42 is a good rule of thumb for a normal SAPIEN 3 prosthesis. The core valve, on the other hand, has a variable dimensionless index and variable gradients. So really, if you want to get a sense of what a normal gradient and dimensionless index is, you'll have to go take a look at the standard values that have been published. However, they do exist. So why do we care about gradients, dimensionless index, and effective orifice areas for the Tavor valves? Mainly because this is going to be the means by which we identify Tavor thrombosis and dysfunction. Shown here are combined data from the SAVORY and RESOLVE registries, accounting for more than 1,100 patients undergoing Tavor and SAVOR, all of whom were followed with a cardiac CT. The risk of thrombosis was 12% overall, and 13% in Tavors and 4% in SAVORs. Thrombosis was identified by cardiac CT. The echo findings that were associated with thrombosis were an absolute mean gradient more than 20 millimeters of mercury, or a change in the mean gradient of more than 10 millimeters of mercury. There was no difference in the stroke rate, but there was an increased risk of transient ischemic attacks. Anticoagulation was associated with a lower risk of thrombosis. Subsequent studies have not shown a mortality risk associated with this, so I think the clinical significance of this finding remains unclear. Based on several other studies, these are the following echo criteria that have been proposed looking for Tavor, thrombosis, and stenosis. Possible or subclinical valve dysfunction should be considered if there is an increase in the mean gradient by 10 millimeters of mercury with a drop in the dimensionless index by more than 20%. And clinically important valve dysfunction is highly likely if there is a change in mean gradient by more than 20 millimeters of mercury with a drop in the dimensionless index by 40%.